So in our final session today, we're going to be talking about regulation and the law, and we've talked a lot in the previous sessions about privacy and the importance of privacy, but also how nuanced it is. To say that you respect privacy or consent doesn't answer the problem. And then in this final session, we're going to be kind of going beyond privacy and looking at some bigger issues. And I'm told that these collaborators are going to be presenting jointly, so I'm going to introduce them both at the beginning, and then after their joint presentation, we will open it up for questions. Professor Sharona Hoffman is Professor of Law and Bioethics at Case Western Reserve University. She's also the co-director of the law school's Law and Medicine Center. And the two of them have a rich collaborative history together, so it's great that we're able to have them presenting together here today. She's published over 40 articles, most of which focus on health law and civil rights law, and she's been widely quoted in the national press. Her current research focuses on health information technology. So join me in welcoming Professor Sharona Hoffman. And Andy Podgorski is also at Case Western Reserve University in the Computer Science and Electrical Engineering, or Electrical Engineering and Computer Science, EECS. That's right, because I thought EECS was clever as an acronym. And he's also written about 40 articles in this area of software methodology, I'm sure much more than that, but in this area, software methodology and computer privacy, so it's a really nice combination of the two. So thank you very much for coming, and we'll turn it over to your presentation and then ask questions at the end.
So since we're all about disclosure, I have a disclosure to make, which is that our collaboration is so rich that we're actually married. And so far, the marriage has survived the collaboration. So. All right, well, most of our presentation is actually about issues other than privacy. But just so you don't think we don't care or know about privacy, I'm going to begin by talking for maybe about 10 minutes about the Hipaa security rule. And the security rule has been mentioned, and a few references to some of our points have been scattered throughout the past couple of days, but I'm going to pull them together and try to have a little bit of a comprehensive discussion about the Hipaa security rule, because it's very, very important. It's the part of the Hipaa privacy rule that actually details what security measures we need to implement for computer systems that store electronic health information. So the security rule was passed in 2005, and it has 4 general standards. It tells covered entities that they have to ensure the confidentiality, integrity, and availability of electronic protected health information. They have to safeguard against reasonably anticipated security threats. They have to protect against reasonably anticipated impermissible uses and disclosures. And they have to ensure workplace compliance. So this is the part of the rule that doesn't talk about what you can disclose to third parties and how important privacy is. This is actually technical safeguards. And in fact, there are 3 kinds of safeguards that the rule requires. First of all, administrative safeguards. And this is things like risk analysis, which is very, very important, because if you're going to figure out what your vulnerabilities are and what solutions you need, you have to have a responsible risk analysis. And also workplace compliance policies, because it's not enough if just the supervisors and managers know about security. Every single person in the workplace has to know about it, because even a low-level employee can disclose information, and then it can be spread to a worldwide audience on the internet instantaneously. Physical safeguards, these have to do with the facility and equipment, and technical safeguards, things like encryption, decryption, authentication. So you have to be able to determine that users are who they say they are and that they have the authority to access the information. So now a little bit of a critique of the Hipaa security rule, and we've actually written a couple of articles about it. We can give you those citations if you want them. So the security rule, like the privacy rule, covers health plans, healthcare clearinghouses, and most, though not all, healthcare providers and their business associates. But, as we now know, it does not cover many others who handle health information, employers, marketers, website operators, and others who have electronic PHI. So not only are those not bound by the non-disclosure requirements, they're also not bound by any of the requirements telling you to have secure computer systems. So they can do whatever they want. And we think that this is a big oversight, as many others have mentioned, and it's just very surprising and disappointing. The ARA, the stimulus plan legislation, did revisit the definition of covered entities, and it extended it to business associates, which was a big step, lawyers, accountants, billing people, but for some reason it did not extend it beyond that. And so in our papers, we have suggested the following definition of covered entities. They should include any person who knowingly stores or transmits individually identifiable health information in electronic form for any business purpose related to the substance of such information. And that is a mouthful, but basically we're trying to avoid the problem of under-inclusiveness. Anyone who's going to handle this data for business purposes should be covered, but we're also trying to avoid the problem of over-inclusiveness. We don't want people who are in their private capacity emailing each other about a friend's illness to have to comply with all the Hipaa requirements. So that's basically the gist of this definition. Now, another issue is that the rule provides insufficient guidance and allows covered entities excessive discretion. I should not have eaten that brownie at the break, obviously. So, first of all, it does have several pages of all sorts of requirements, risk analysis, encryption, and so on, but it doesn't tell anybody how to do those things. And most healthcare practices are not going to have a sophisticated IT department, and so they really need much more guidance than they have. The rule also allows covered entities to choose the means by which to reasonably and appropriately implement the standards. So again, if you don't have an IT department, how are you going to make these selections? And if you do have a good IT department, well, all this discretion might actually allow you to circumvent the purposes of the rule and to implement the minimum. Now, there is a challenge in this area. We are trying to create some kind of fixed rules for a dynamic technical domain, right? Security threats and security solutions are ever-changing. And so you can't spell out, use this technology in that program, because by the time it's published, those techniques will probably be outdated. So you need something that provides guidance, but is also quite flexible. And so another complicated suggestion that we've made is a best practices standard. So this would be something such as requiring covered entities to make reasonable efforts to identify and employ best practices relating to security measures, software development, validation, and maintenance, and software system administration that are either commonly used by similarly situated business entities or governmental institutions, or can be clearly demonstrated to be superior to best common practices. So you wouldn't have to reinvent the wheel. You would simply have to show that you are using the best technology out there, or if you're really sophisticated, that you've invented something better. Now again, small practices without IT departments are going to have difficulty doing this, but they can hire vendors who have expertise and can identify commonly used practices. And there are all those standards and programs that we heard about earlier today, which do provide guidance. So there are some resources out there, and we can talk more about those in the question and answer period. The final thing I will mention about the Hipaa security rule and really the Hipaa privacy rule in general is that it is a real gap and shortcoming not to have a private cause of action. Enforcement is left up to the government. At first, it was CMS enforcing the Hipaa security rule on its own, and enforcement was extremely anemic. Now, under ARA, actually under high-tech, state attorney generals can institute litigation, but I'm not sure how often they're going to do that. And so if we want meaningful deterrence and also a meaningful remedy in cases where somebody does suffer harm, we really need a private cause of action. And so those are some of the suggestions that we've made in the paper, and we just thought it was important to address the Hipaa security rule specifically rather than just the Hipaa privacy rule in general. And now I'm going to shift gears into the crux of the talk, which is beyond privacy. Right? As important as privacy is, it's not the only concern generated by electronic health record systems, because these systems are much, much more than electronic paper records. And so they raise a lot of concerns about patient safety and about achieving good outcomes, not only about improper disclosures. Now, why is that? Well, electronic health record systems have a variety of features. They are record systems, so your clinician is going to be typing information directly into the computer rather than taking notes or dictating notes later. But they also provide clinical alerts and reminders, and so messages will pop up on the screen saying it's time for the patient's annual mammogram, or it's not annual anymore, I don't know. However often it's time for the mammogram, or this patient is allergic to penicillin. Sophisticated systems also can provide other forms of decision aids. So you might type in symptoms and the system will suggest diagnostic tests or diagnoses or even treatment plans. So you might get your treatment plan directly from the computer. They provide links to medical literature so the physician can do research concerning whatever condition is at issue. And very importantly, they provide computerized physician order entry so that the physician sends the order electronically directly to the pharmacy or the lab or the radiology center. And if this order is incorrect or is mangled in the process of transmission, that can have catastrophic results for the patient. They get too much radiation, the wrong dosage of medication, etc. There is secured messaging. And so some systems allow patients to communicate electronically with doctors. I think patients like that a lot. I'm not sure about doctors. And PHRs. So the patients in some cases can actually look at some information such as lab results, appointment schedules, and other information that is included in the electronic health record system. And they provide data analysis tools which enable searches. So if a medication such as Vioxx is recalled, the doctor ideally should be able to search electronically and easily find all the patients that are taking this medication and then communicate the relevant information to them. And finally, interoperability. This is extremely important. We're not exactly moving in this direction, but this would allow all systems to communicate with each other, which does generate a lot of concern about privacy. But if you go to a different facility for a second opinion, or to Florida for the winter, which is very appealing if you live in Cleveland, or to the emergency room unconscious or uncommunicative, those doctors would be able to access your health record with proper authorization, no matter where it's located, and get critical medical information. Now, as I said, we're not really moving in that direction in Cleveland. The Cleveland Clinic and University Hospitals, which are the two major systems, have purchased EHRs, but they're different and they can't communicate with each other at all. So these are some of the functions that give rise to a lot of concerns. And I'll just give a brief overview of our argument. and that is that we need to ensure the safety and efficacy of these systems. We need to have quality control over all of these features, including a careful approval and monitoring process, just as we have that for medical devices that are approved by the FDA, though their approval process, we need a better one. Their approval process has been criticized as well. And we need specific standards and criteria for the key features to make sure that they're of high quality and actually improve patient care. So I do most of the talking in the marriage, but I'm actually going to let Andy do a little bit for a while.
Thank you, Sharona. At the risk of offending the gods of Microsoft Office, I'm going to try to bring up a web page that I was alerted to just yesterday. This appears at nextgov.com. The article title is Glitch Prompts VA to Shut eHealth Data Exchange with Defense. And basically what the article describes is a problem with the health information interchange that DoD and the VA have been working on since 2004 that will allow VA physicians to view medical information for Defense Department employees, and I assume vice versa. Basically, there was a problem that arose just recently that resulted in about 1 in 100 patients, doctors getting either the wrong record or an incomplete record or no record. And it was, I believe, first discovered, as indicated in the article, by a doctor who was treating a female patient, and her record said that she had been prescribed Viagra or something similar. He thought that was suspicious, and he followed up on it. And it turned out that it was actually a serious problem with the system. They've got a fix for it. They've shut down the interchange for the time being. This particular problem is probably not a long-term problem, but it illustrates something very important. EHR systems are becoming, and will become more so in the future, the platform that enables a lot of healthcare in our society, particularly in large medical centers. And the providers are going to become more and more dependent over time on the correct functioning of those systems, and therefore they and their patients are going to become more and more vulnerable to software defects and other problems with these systems. There's two with this similar names. Okay. There we go. Okay. So, in case you forgot, what are the benefits of EHR systems? What are the claimed benefits? Well, one of the big claims that's been made is that they reduce errors, reduce medical errors. And there's been a lot of controversy about this, and there's mixed evidence about it. There are studies, for example, that indicate that order entry systems, which are a component of sophisticated EHR systems, actually do help reduce errors in prescriptions, for example. There are other studies that indicate that under certain circumstances, they can actually increase the number of errors. So the results are mixed. More generally, the idea of having relevant health information available to the providers who need it when they need it, wherever they are, and regardless of where that information was originally collected, obviously should help reduce medical errors. Doctors need to know about patients' relevant medical conditions, their medical history, their treatment history, and so forth. So it's intuitive that in that respect, EHR systems should help reduce medical errors. They should also be able to help because doctors won't have to read other doctors' handwriting, which is a notorious problem. Also, these systems can do safety checks, for example, on drug dosages. As Sharona pointed out, they have various forms of decision support. They have alerts and reminders. All of these things potentially can reduce errors and improve patient safety. Through their reminder features, there's good potential for them to improve preventive care, and there is some evidence that that's actually occurred, that doctors actually appreciate the reminders that the patients need their yearly, biannual, or whatever mammogram, for example. They appreciate those reminders. They don't so much appreciate intrusive alerts and notifications, which seem to get in the way, particularly if they're not that relevant in their opinion. EHRs facilitate communication, particularly if they are distributed, if they are interoperable, which is a big if, since most EHRs are not interoperable with each other. But if they were, that would be a great boon. That would mean wherever you went to be treated, with your permission, the treating physician could access your medical information. Another controversial benefit, a claimed benefit of EHR systems is that they will reduce medical costs. And there's a famous estimate floating around of over $70 billion worth of savings. That's been much disputed. I think it's fair to say the evidence for cost savings is not there yet. There are reasons to think it's possible, but it remains to be seen. One big issue with adoption of EHR systems is the cost. One estimate has it that it's going to cost for an individual doctor to acquire an EHR system, it'll cost $33,000, and it'll cost an additional $1,500 per year per month for maintenance. That's pretty stiff. Obviously, the ARA includes some funds to help doctors purchase EHR systems. It remains to be seen whether that will cover all of their costs, and there's, as many of you are aware, controversy about that. A recent study indicates that only 17% of physicians and 10% of hospitals have true multifunctional EHR systems. A somewhat higher number have parts of EHR systems, have some EHR system functionality. Another issue related to cost is training. When you install an EHR system, you just don't turn it on and start using it. Your staff needs to be trained. It can be an extremely disruptive and error-prone process. It can take months. If you don't roll it in just the right way, it can disrupt the operations of your office or your hospital. So that's a serious issue. And it requires work habit adjustments. It can require an organization to change their workflow, which is potentially very disruptive. Okay, what we're mainly concerned with in our most recent work on EHR systems are the issues of safety and efficacy, as Sharona mentioned. And there are many shortcomings that have been described with existing EHR systems that can contribute to safety issues with patients. One is the general area of information overload. Many physicians, not just older physicians, but they tend to complain the most, complain bitterly about the inaccessibility of information on EHR systems. They know it's all there, but they can't find the relevant information when they want it. They complain about the displays, about the fact that they have to go through reams and reams of data to get at what they want. They preferred the old system where the information they wanted was on page one in a folder. And in many cases, they're disgusted with the EHR system they have to work with. Other doctors, often younger doctors, but often doctors working with some of the premier EHR systems in the country are much happier with them. The issue of cut and paste was mentioned. This is actually an insidious form or source of errors where to lower the burden of typing in a lot of information, people cut and paste text from one portion of their notes to another portion, And that actually is something that software engineers do when they're writing code, and it's well known to cause bugs in software. It also causes bugs in EHRs, because often what's copied is not appropriate to the current situation. And we've heard one anecdote about someone who had their leg amputated, but part of their record that indicated they had problems with their leg was cut and pasted after the time of the amputation, so it appeared that they still had a leg at that time. That's kind of humorous, but you can imagine how that kind of error could lead to serious consequences, like cutting off the same leg twice. Decision support is tricky business. You're getting in, these systems are attempting to help physicians through alerts and reminders, but they're getting in their face. They're popping up things that they don't necessarily want to see. They may or may not be relevant. There are often complaints that they're not relevant. For example, drug interaction warnings many of the times may be false alarms. The doctor may immediately dismiss the warning because he knows what he's doing. Once in a great while, they'll be warned of a truly dangerous drug interaction they didn't anticipate, and then it may be, they may be thankful that it's there. However, they may also, because they're irritated by all these unhelpful warnings, turn the feature off, and therefore they'll miss that one warning they really needed. Software defects are a big issue, and I think a neglected issue. People tend to assume that these systems are just paper record systems on a computer. They're not. As we've indicated, they have a lot of rich features. They're pretty complex software systems. They interact with other hardware and software systems, and they're only going to get more complex in the future. So, like all complex software systems, they are subject to defects. I'm a software engineering researcher. I've studied software defects all my life. They're a big issue, and this is a safety critical system in the sense that in the aggregate, because so many people are going to be treated through these systems. So even seemingly innocuous software defects can turn out to be quite serious. One of the main sources of problems is usability issues. Very often, even if the system behaves correctly in the sense that it does what it's supposed to do, it may confuse the user, confuse the physician, and lead them to take an incorrect action and therefore harm patients. So there's a subtle issue of usability of human-computer interaction that is particularly important with this class of systems. And we've heard of some real horror stories about what happens in hospitals when their EHR system goes down for an extended period. Once they become...
Like the shower this morning.
Once a hospital becomes dependent on an EHR system... I don't know how to follow that. Once a hospital becomes dependent on an EHR system, if it's suddenly not available, things can go to hell in a handbasket very quick. Okay, I'll hand it back to Sharona to talk about liability.
Okay, so for the doctors in the room, just to raise your anxiety level for the weekend, there are all the problems that Andy mentioned, of course, can raise liability concerns and expose doctors to liability. So there are time constraints and system demands. The most generous estimate that I've seen of how long a doctor's visit lasts is maybe 15 minutes. I can't remember the last time I actually had a doctor in the room with me for an entire 15 minutes, but let's go with that. Well, these systems demand a huge amount of information, and so doctors complain bitterly about the amount of time they have to spend working with the computer at the bedside or in the examination room. And some of the features are meant to maximize billing opportunities. You have to click on all sorts of things and then you can charge. and some are just meant to create a comprehensive record, but it's a lot of work for the doctor. And if all you have is 15 minutes, it's a big problem if you have to spend 13 of those minutes dealing with the computer. And so we've heard doctors tell us that they resent these systems, that they don't feel they have time to listen to the patient, examine the patient, use their intuition to figure out what's going on with the patient. And we've heard patients say that they resent it, that the doctor seems to care a lot more about the computer than about them. There are ways to address it. I've talked to some patients who say, no, it's a really good thing. The computer is positioned in such a way that I sit beside the doctor and we look together at my medical history and prior test results. And so some of this might be addressable through adjustments in attitude, communication, positioning of the computer, but it still can raise concern and some hostility between doctors and patients. And of course, if you have a comprehensive EHR that consolidates the records from birth until now, or what somebody said, from sperm to worm, I'm going to have to remember that. Is that right, Maya? The doctor is presumably responsible for all that information and is supposed to walk into the room knowing every single thing about the patient. And if they miss something, like a surgery from 10 years ago that was right in the record that might affect what's going on with the patient now, they could be liable. Relying on others' diagnoses. So Andy mentioned the estimates that we might have a lot of savings from these EHRs. Well, the savings are associated primarily with three things. One is less duplication of tests, because once you do the test, everyone can access the record. You don't have to do that again. But there's a downside to relying on others' diagnoses, of course, because maybe the other test was not done well. Maybe if you could do it over, you would take the X-ray from a different angle or do a different type of CAT scan. And maybe just enough time has passed that some things have changed, and yet you're going to get economic pressures or insurance pressures not to do the test over. And of course, there are other sources for the cost savings. If you do enhance patient savings and have fewer medical errors, that will save costs, and there's some administrative efficiencies as well. But the liability may come from relying on others' diagnoses if those are incorrect. Input errors, of course, you could have errors in a written medical chart and illegible handwriting, but if you're desperately trying to put in all the information by typing quickly, and in fact some of these screens won't let you go on to the next screen until you've typed everything in, then you could have liability arising from input errors, inverting numbers in a dosage or something like that, and cut and paste. Decision support, Andy mentioned that. Well, if you are inundated by decision support messages and you're just hitting escape, escape, escape to get rid of them, there is some likelihood that you'll actually miss something important, or you won't think about something that you would have thought about if you weren't inundated with all of these messages all the time. Electronic communication, that can be a very good thing, but you don't want patients emailing you in an emergency. And if you don't educate them about it, and some people have said you have to have them sign an informed consent form so that they know not to email you in an emergency, there can be liability from allowing them to die because they've emailed you that they have a problem and you just haven't responded. They think you're at your BlackBerry looking at messages all the time, as I see some people, in fact, oh, I won't mention that. So patients, you need to manage the electronic communication with patients. Patient access to PHRs. There are a couple of issues here that again can give rise to liability. First of all, you don't want patients getting really bad news from the PHR. You don't want patients learning of a cancer diagnosis from getting a test result on the computer when they're by themselves. So you need to be able to withhold some information so that you can have a face-to-face conversation and counseling and make sure the patient is okay and understands everything. And some of these PHRs also allow patients to input their own notes. Well, if patients think the doctor is reviewing it and therefore during the appointment they don't tell you critical things because they typed it into the PHR, that too can lead to liability and is something that needs to be carefully managed. And of course, if there are product defects and something went wrong with the EHR system itself and some harm was caused to the patient, well, the doctor might be liable for that harm as well, even though it's actually the computer that is the origin of the problem. All right, so that's for doctors. For lawyers, there are some issues that arise in litigation. So, for example, will use of decision support be a defense? If you do follow the computer's instructions, is that going to be a defense? That's something we have to think about that we haven't thought about yet. Are cases going to grow and become even larger and more complicated than they already are? Because patients will just throw vendors into the case no matter what, on the off chance that some of the problem is due to a computer error or to poor computer design. Why not? EHR vendors have deep pockets. They might give you some money. And in fact, how will failures of complex EHR systems be proven? It's very, very difficult and will require highly paid and very knowledgeable experts, because the problem might be in one line of code out of millions, Andy tells me. And so will patients be able to afford those kind of experts? Will doctors be able to afford those kinds of experts? And will fragmented displays, incomplete data, and so on impede record review, right? It's difficult to review computer printouts. It doesn't look like the medical file that we're used to with the nice tabs and the summary sheets and so on. You might get thousands of pages of a printout, and who knows what that means. We hear complaints, it's all in the same font, it's all in the same color. You can't find the details that you need easily. And there's also a problem of actually, despite that big volume of information, having incomplete data. Because when you get a PDF or a printout, nobody's there printing out the hyperlinks, which are in the actual electronic health record. And so if you click on the cholesterol test, for example, it might give you all of the cholesterol tests that you've had in the last 5 years. But if you get the record, that hyperlink is not printed in a coherent, comprehensible way. On the other hand, there are some advantages in litigation. Ooh, that's giving me some motion sickness. Okay. If you have a good EHR, it could faithfully record all medical interventions, all patient interactions, and everything that the computer itself did. So you could have audit trails which will facilitate discovery of the truth. And again, a well-designed system should allow for electronic searches of medical records. So if you're looking for a particular detail, you might actually be able to construct a query and get it at your fingertips rather than having to plow through large paper files. So as I mentioned earlier, our basic argument is that we need federal regulation. These systems are not just word processing systems or library systems. They are going to manage many aspects of patient care through decision support, through computerized ordering, and so on. And so they're safety critical. And we regulate all sorts of other safety critical areas. We don't let airplanes fly with no regulation. We regulate transportation. We regulate food, drugs, devices. How could we not regulate EHR systems? Now, we do have CCHIT, the Certification Commission for Health Information Technology. This is an industry-based organization. It's not a governmental entity. And we've carefully studied their certification process, and we believe that it has many shortcomings. Testing lasts only 1 day, 8 hours. That's all you get. And applicants are given the testing scenarios in advance. So they get to practice everything they're going to be asked to do. There are no spot checks, no surprises, no testing of what happens in an actual clinical setting where you can't anticipate everything. And CCHIT criteria don't address important matters such as usability. So you could have a very, very good system, but if it's not user-friendly and your workforce can't learn it, there are going to be a lot of errors. And training is a big issue. We talked to one doctor from Kaiser who told us that in his little practice group, they had to reduce their patient load by half for a couple of weeks in order to get training. So maybe you can do that at Kaiser, because you can just send the patients to other Kaiser doctors, but if you're a small independent practice group, you can't really do that, and that's a big problem. And so we do think that we need federal regulations. Now there is increased governmental involvement and government oversight as a result of ARA, of the HITECH Act. And so we do have the Office of the National Coordinator for HIT. We have representatives here. The 2009 legislation set up the HIT Standards Committee, the HIT Policy Committee, and they are doing very, very good work. And ARA also provides for subsidies for meaningful use of certified systems. But we have to figure out what meaningful use is and how systems are going to be certified. And if it's just going to be a continuation of CCHIT, we don't think that's good enough. We are not aware that they are talking about comprehensive regulation that will be binding on everyone. In fact, there is language in the legislation that says that they'll produce standards and criteria, but that these will be voluntary in terms of compliance. And Andy's going to take over again from here.
So what do we think that the regulation should do? First of all, we think that they should establish an EHR system approval and monitoring process. And this would be somewhat different from, say, the regime that FDA uses with safety critical medical devices. In particular because we think there should be more reliance on observations of the system in the field, that is, in actual use in a clinical setting, actually in a variety of settings over an extended period. In fact, we think the system should be monitored throughout their operational life because these systems will undergo constant maintenance, revision, customization, bug fixes, etc. And all of these things can affect the safety and reliability of the system. For example, a change in the decision support rules could have a major impact on patient safety. And so there needs to be continued vigilance with any one system to make sure that errors are not introduced, and if errors do occur, that they're caught quickly. So we recommend that new products be field tested for a period of at least 6 months, ideally in a variety of settings. We recommend that there be for each system what we call a system oversight committee, and we borrowed this idea from some other health IT researchers who proposed it over a decade ago. And the idea is basically that this committee will include physicians, HIT experts, perhaps some patient representatives, and they will be responsible for reviewing adverse event reports and reports of usability problems and so forth, and making decisions about how to mitigate those problems, how to respond to them, and whether federal authorities need to be informed, and so on. Now, also as part of the regulations, we think that a number of criteria need to be established. We hear the word interoperability a lot. From my perspective as a computer scientist, interoperability means that these systems can exchange the content of an electronic health record and use it as if it was a native record. That's an ideal. That doesn't mean a text file or a PDF. That means they can essentially one system can upload a record from another system and use it. That goal is a long, long way off. And there is no evidence that I've seen that vendors are moving in the direction of trying to achieve that, moving seriously in the direction of trying to achieve that. There are organizations such as HL7 that have made steps in that direction. In my view, those efforts will never come close to achieving true interoperability. Someone, either a company with a monopoly or the US government, has to come in and say, this is the standard, live with it. And that will be very upsetting to many providers, to many EHR vendors, because it will mean a lot of work for them. It will mean doctors will have to get used to one way of expressing medical information. That's a tall order. There'll be fierce objections to that. But if you don't do that, you cannot achieve interoperability. Sharona mentioned audit trails. We believe they should be required not only for security, but also for safety. I won't get into security requirements since Sharona already talked about that. We think there need to be rules for the safety of decision support mechanisms and for the general design principles for decision support mechanisms, for validating them and so forth. I used the example earlier of the decision support rules for a system. These are rules that determine whether a doctor is warned of a potentially dangerous condition, for example. And they're essentially, one way of thinking of them is as simple computer programs. But they're safety critical computer programs, and they vary from one installation to a system to another. Any local system that can customize their decision support rules can change them, and therefore they can mess them up. So there need to be special processes to minimize the chances that they'll mess them up. Again, we think that the idea of a best practices standard backed up by private litigation is probably the best way to motivate vendors to produce high-quality systems. I won't go further into that now because Sharon has also talked about it. I do want to save I did try to save a little time to talk about something that I think is very relevant to this conference, which is an idea that others have proposed and we discussed in one of our papers, the idea of using what will hopefully be the National Health Information Network to establish a massive national database of de-identified electronic health records that will be made available under restrictive conditions to legitimate researchers to do medical research. What I want to emphasize are the potential benefits of doing this. Right now, most medical treatments are approved and through the process of clinical trials. In other words, they have to be shown safe and efficacious in a clinical trial, which might involve a few hundred subjects, perhaps a few thousand subjects. And usually the conditions of the clinical trial are not well, depending on the nature of the trial, they may not be that similar to the way the treatment would be used in practice, in the field. For one thing, it's researchers who are guiding every step of the trial, which makes it different from when the treatment is available to physicians all over the country. Being able to use a database like this to do observational studies, large-scale observational studies of treatments as they were done in the field could help us establish the true effectiveness of treatments, in particular their comparative effectiveness, their effectiveness as compared to each other, and help us improve the quality of medicine by establishing what really works and what doesn't work. To the extent that electronic health records are fragmented, are put in silos, are restricted, are made incomplete, including in the name of privacy, we limit the potentially great social benefit that could come from the kinds of medical studies that I'm talking about. And there's very little discussion of this in the public domain about the great benefits that could accrue in the public interest from making this kind of information widely available to legitimate researchers. One of the important requirements for doing this kind of research is that the data, the sample of electronic health records that are being studied, be representative of the true patient population and all its diversity. And again, to the extent that electronic health records are fragmented, siloed, restricted, made incomplete, and so forth, that makes it very difficult to get a representative sample to do these kinds of studies. So, for example, if Rush Limbaugh tells his listeners, whatever you do, don't agree to allow your records to be contributed to the National Research Database, then our samples for research studies from that database will be horribly deficient with regard to reflecting the particular health issues of his listeners. I'm being facetious, of course, but to the extent that we care about those listeners, that might lead to serious bias. Of course we do. That might lead to serious bias in the studies. If African Americans refuse to participate, that could lead to serious bias in the studies. If uneducated people, rural people, you name it, prefer not to be involved and they withdraw their records, then that means that the sample on which we do our medical study will not be representative of them. The results will be biased, and as a result, will be ignorant of facts that are relevant to those populations. So this is a big issue. And I have to say that this conference has awakened me to some risks that privacy poses to this kind of research, which I think it has a fantastic potential. I appreciate the privacy issues. I think they are important. But if patients understood what they stood to gain from this kind of research, if it was done well, they might feel differently about these issues. Okay, I think I'll
put the slide with our papers.
Oh, yeah.
The most important one.
Here's some of our papers.
The most important slide here.
Finding a Cure came out last fall. That's the one that talks about the regulatory framework we've mentioned. That's in the Harvard Journal of Law and Technology. We have a paper coming out shortly in the Berkeley Technology Law Journal, which talks about the litigation issues that, liability issues that Sharona talked about. We have a couple of papers on the Hipaa security rule. One is mentioned here, the Securing the Hipaa Security Rule from the Journal of Internet Law. There's also a piece that appeared in the Boston College Law Journal in 2007 on Hipaa. Okay, thank you.
Great. That was great. Please join me in thanking Professors Podgorski and Hoffman.